This is a production of Cornell University.
Welcome to the podcast of Mann Library's Chats in the Stacks Book Talk series. In today's talk, originally presented on November 30th, 2009, Cornell's policy analysis and management professors Coasley Simon and William White discussed the current debate on healthcare reform in the United States, providing a comparison of legislative bills passed by the U.S. Senate and House of Representatives in 2009 and identifying key issues to watch as reform action proceeds in the coming months.
Thanks for joining us. I was greeted by one of my colleagues by saying they could hardly wait to hear what I had to say. And my response was, I could hardly wait too. This is a very complicated topic and a very fast-moving topic. What we hope to do today is give you a little sense of some of the issues. I can guarantee you that you will undoubtedly be able to ask at least 5 questions that we don't know the answer to. But hopefully we can help you get a little understanding, more understanding of what's going on. So, providing a brief overview, we're basically in the, we're going to talk a little bit about the legislative process after giving some background, then focus on a couple of key issues that we think are important to watch right now in the current debate. Stay tuned, there may be new ones. The mortality rate is high on some of these things. And then talk about the bottom line in terms of what's going to happen with these, may happen with these bills in terms of what the impact on the uninsured and on costs. So if we think of the kind of key challenges in reform, one key challenge is dealing with the problem of the uninsured, that is people that have no health insurance. And right now, that makes up about 17% of the US population. I'll talk a little more about sources of coverage for this group, the non-elderly US population. The elderly are in a little different basket because of Medicare, which is basically an almost universal health insurance program here for people who are over 65. A second major issue is healthcare costs. Right now, well, as of last year, healthcare costs were around 16% of the GDP. Growth has slowed down. Healthcare growth is not, so that number will probably go up the next time we see it. And if you look at some of the projections, it's really pretty frightening. If healthcare continues to grow the way it has, some of the projections put it up around 20, 30% of national income in fairly short order. And so there really are two kinds of cost issues floating around in the current debate. The one is, how much will these particular pieces of legislation cost? The second question, which is really running background and is a much bigger question, is how are we going to deal with the fact that healthcare has consistently, expenditures have consistently grown faster than total GDP. So their share of income has been steadily rising. And you may have heard some of the discussion about bending the curve. Basically what that discussion is about is how can we get the growth rate of healthcare costs more in line with the overall growth of economic product. Finally, the third major concern is quality of care, where you've probably heard a lot of discussion about medical errors. There's also a much broader issue about how we can really improve system performance. Some of the big topics in this area have been health IT, innovative new kinds of payment systems that may create better incentives for integrating care. One of the features of our system is not that it's highly fragmented and that the left hand doesn't talk to the right hand. IT might help, but so might incentives for them to talk. And then things like comparative effectiveness analysis as a tool for improving things, which I might add can be quite controversial. You probably saw the furor in the papers last week about proposals, recommendations on mammograms as to whether people under 50, women under 50 should have them, set off a huge brouhaha. So this is an area where I think there's a lot of room for improvement, but also a lot of potential for controversy. Now, looking specifically at the uninsured, who have been a major focus of this debate in terms of what the overall patterns of coverage look like, as I said, there are around 260 million Americans under 65. 17% of them have no insurance. If we look at where other people are insured, the vast majority are insured in the employer market. And this is a very important point to keep in mind as we start to talk about the reform proposals, because if you're trying to influence coverage on the private side, you basically have to think about how any steps you take are going to affect the offerings of insurance for employees. And I suspect, most of you, at least those of you who have jobs, have your insurance through your place of work. In fact, only about 5.5% of the population actually buy insurance on an individual basis. And there's a good reason for that. That insurance tends to be very expensive. And I think we'll talk about the issue more later, but a key issue there is not only that selling policies to individuals involves more costs, but also that when you're selling to individuals, there's much more potential for self-selection and adverse selection, where if you think about it, if individual insurance is expensive, who's going to buy it? Probably the people who anticipate the highest levels of health utilization, and guess what? Your prices are going to go up even more. And so you're in a situation where this is a very difficult market to operate in. The advantage if you take Cornell employees as a group, most people probably don't select Cornell as an employer or be selected by Cornell on the basis of their health status. So that solves some of this adverse selection problem, although in smaller firms it can be a big issue. The other important group is the public share, which for the non-elderly population, it's around 14%, where big pieces of this are Medicaid. Medicare also covers some non-elderly who have particularly severe health conditions, and the military. So I'm going to turn it over to Kosely now to talk a bit about the aims of health reform bills, specifically against that background.
Thank you, Will.
We
have a handout that we're going to pass around as part of the slides that we're going to show. So
lots of fine print.
What we're going to talk about in this slide is basically what the broad aims are of the healthcare reform proposals, without distinguishing yet really what's in the Senate bill that's different from the House bill. So one major aim is to increase the number of people with health insurance. So this is done through a number of what we're going to call demand side policies. Basically, it's working at the level of the consumer to try and increase the number of people who have coverage through encouragements and fines. So carrots and sticks. The major carrots involved here are subsidies to the uninsured to buy private coverage, as well as expanding Medicaid coverage. And the Medicaid coverage expansions are not just limited to children, but to all non-elderly up to either 150% or 133% of the federal poverty level. The sticks involved are fines, and these are both at the individual level as well as employers. So if there are people who are uninsured, they would face a fine of some degree, and if there are employers, larger employers who don't offer health insurance, they would face some degree of a fine. The second major aim is to change the way health insurance is being sold in the private insurance market. And this we're going to call on the supply side, because this is changing the way that the insurance companies and the insurance market operates. So basically the biggest changes here are in the ways that prices are set for health insurance policies and the details that go into determining the price in mostly the individual market and the small employer market. So these are the markets in which community rating does not exist currently in all states. New York is different. And so these rules would be changed so that people with existing health conditions at the point of purchasing coverage would not have those conditions count towards determining their price. They would be essentially the same price for sick and healthy individuals. And there's some restricted adjustments that are allowed for age. There are also a set of policies to improve the minimum generosity of these plans to make sure that they all meet some minimum levels of coverage, and that there are improved consumer protection provisions. Major way in which this is envisioned is through creating a health insurance exchange, which is basically just a marketplace where all these plans will be available, and it will be easier to compare across plans when making purchase decisions. And these exchanges would be, at least initially, open just for the uninsured and small farm workers to buy into, but would eventually grow to include other firms. And then there is this very controversial, in the press, the idea of adding a public option. But it's important to note that this is not envisioned as an extension of an existing government program, but creation of a new plan. So we'll have more to talk about these details later, but just wanted to mention that there as a change in the rules of the way insurance markets will happen. A third major feature is reducing the growth of healthcare costs. So finding out ways that even if we weren't to expand coverage, ways that we could try and improve the efficiency of the delivery of healthcare right now and find ways to reduce costs. So those include reforms to the payment system under Medicare, taxing some high-cost health insurance policies, and some other changes, including changes to Medicare Part D. Under miscellaneous, I've put other features that are, some are just revenue-raising features, but also hope that they would increase efficiency somewhere down the line. New taxes on pharmaceutical companies, device manufacturers, high earners, health insurance companies, or a variety of those kind of features. So now what we are going to say is, let's take a look at where we are in healthcare reform, where the bills have been pitched, and then we'll get into the differences between the bills. So there is the Senate version of the bill on which debate began today. This is we're likely to see many amendments introduced to this bill before there's a vote that the Senate takes on this. So this is the Patient Protection and Affordable Care Act. And if and when a final bill emerges from this, it would be then conferenced together with the House version of the bill, which already has passed the House, and would then arrive at the president's desk. If signed, would then turn into the implementation stage. So this is kind of where we are right now in just this political process. And so paying particular attention to the differences between the House and the Senate version we thought was something we'd talk about, since so first I have to just say that there are thousands and thousands and thousands of pages behind these bills. So as a disclaimer, I can certainly not do credit to put these into 3 slides what the differences are. So basically these are just my reading of what seem to be major similarities or differences between these bills, and are things that might come up when the bills get to a emerging stage. So the first element along which I'm going to compare bills are subsidies, then fines, then get into other features like how the exchange is determined, what the cost containment features are on the other slides. So basically, in terms of subsidies, the two bills are fairly similar. They both envision there being income-based subsidies to individuals based also on the basis of whether they work for small firms or not. So they're fairly generous subsidies when you consider the lower end of the income spectrum. But when you're getting to the higher end of the spectrum that will get subsidies, that's 400% of the federal poverty level, both plans envision subsidies going up to that level, but phasing out pretty fast as you go, even beyond 150 to 200% of the federal poverty level. So there's also going to be, there's assistance both with premiums as well as with cost sharing. So this legislation is taking into account that the premiums themselves aren't all that the families face as financially burdensome, but that the cost sharing can end up being burdensome too. So there are limits on how that would be facing low-income families. There are going to be tax credits to small employers. Those also phase out pretty fast. These are to small employers with less than 25 workers, with low average wages. There are some other provisions like providing help to employers who provide retiree coverage. So in those elements, the bills are pretty similar. There are more differences when it comes to the fines. So the carrots are similar, but the sticks are going to be there's bigger differences there. So in terms of the fines, basically the House bill has stronger fines than the Senate version. In the House version, employers that have larger payroll, so basically larger employers, are going to face up to 8% of payroll as a fine for not offering what is termed acceptable coverage. Individuals can pay up to 2.5% of adjusted income if they don't buy health insurance. So on the Senate side, the fines are much lower in the sense that for employers with more than 50 workers, the fine is $750 per year if not offering coverage, and on the individual level, $750 a year. And these fines are not phased in until much later in both of the versions. Then on to the creation of this exchange. There too, it's fairly similar. There's lots of provisions that state that at least initially it'll be to uninsured workers and small firms, but afterwards may open up. There's also this question of whether it's going to be just state-based or national. And whether states can opt out of the plans, out of having an exchange. And so there are some small differences, but basically pretty similar in those areas. When it comes to the public option, there too, the versions are fairly similar, in that both are considering plans that would be financed through premiums and not subsidized somewhere else, and could be at the federal or the state level. So there too, I'm just going to leave it at that because we'll get into more details later on that. Health insurance exchange rules. Here too, fairly similar. Basically, fairly similar between the plans, but big changes relative to the current situation. So there would be a prohibition of health-based price variation for insurance. There would be some variation allowed for age, and the allowance for age is less in the House version than in the Senate version. There's going to be a severe restriction on the exclusion of coverage of conditions that existed prior to purchasing the policy. Right now, many insurers will have policies that say for the next, however many months, you will not be covered for things that you had at the time of purchasing coverage. There's also going to be minimum standards that plans will have to meet in financial requirements and in disclosures. And there will be risk adjustment of payments between insurers. So insurers are going to have less to worry about whether they will end up with the sicker people of the people who are insured, because there'll be ex post adjustments given to adjust these payments. There's going to be an increase in dependent coverage age limits. So there's no law. Right now, the coverage limits for dependents end fairly close to graduation times, and this is going to be extended to about age 26 or 27 in the two plans. So that too, I'd say fairly similar. Medicaid expansions. Here there are two differences. One is that in the Senate bill, the expansion is envisioned to 133% of the federal poverty level, and in the House bill to 150% of the federal poverty level. So there's a group of individuals in that bracket for whom this will be different. But even so, there are still income-based subsidies available to families in the 133 to 150% of the poverty level that make it not as big a deal as otherwise. There is going to be a fairly big change in policy proposed in the House bill in terms of what Medicaid physician payment rates are. Currently, states set Medicaid physician payment rates and set them to be much, much lower than what Medicare reimbursement rates are. And in the House bill, it's envisioned that by 2012, Medicaid physician reimbursement rates will be increased to be on par with Medicare physician payment rates. So that will be a big change. Now, states would normally see these two things, expansions in Medicaid and increases in reimbursements to physicians, as being really difficult to pay for. The bills do say that almost all of this additional spending that states will have to do will come from federal money as opposed to matched state and federal, which is how most of Medicaid and services are financed. There's also, another difference is that so the Senate bill does not have this feature of changing physician reimbursement rates. The House bill has a change in the children's health insurance program, where over 150% of the federal poverty level, those children, so CHIP basically goes up to about twice the federal poverty level. Those children will be purchasing coverage through the exchange with subsidies as opposed to being on the CHIP plans themselves. Another big difference comes in this other taxes category, and that is that in the House version, there is a tax of 5.4% on those earning over $500,000 a year as an individual or $1 million as a family. And that feature is expected to bring in a lot of revenue, close to $400 billion over 10 years from that feature alone. And that's different. That's a big difference because that's not present in the Senate version. Instead, the Senate version has a tax proposed on expensive health insurance plans, so-called Cadillac plans, which we'll also go into more detail on. Other than that, they have similar restrictions in what's going to happen with amounts that can be contributed towards flexible spending accounts and so on. Sorry, one more thing is that the Senate version has fees that will be imposed annually on the prescription drug industry, medical devices, health insurance. It's on the order for health insurance of about $7 billion a year in fees. Okay, so the big, the cost containment, this is a huge area that I've condensed to very little, few words. They are basically similar in that there's changes to Medicare payment rates, experiments with trying innovative designs of how to pay for care through delivery system changes, reimbursement for readmissions will decrease, and so on, different things. I think the differences in these provisions come in what's envisioned for Medicare Part D. Under the House bill, it's proposed that the government would negotiate prices for prescription drugs under Medicare Part D plans, and that's a big feature because that's been not included in Part D legislation so far. So that's not there in the Senate bill. Instead, the Senate bill, in terms of Medicare Part D, does have some changes in premium subsidies based on income. On prevention and long-term care, both these things, there are creation of task force to study these issues. In terms of long-term care, some incentives to improve the community dwelling circumstances, so subsidies given to community dwelling long-term care assistance, and they're fairly similar in the two bills. So in the last category, I have other things that aren't necessarily just related to cost containment or to improving insurance rates per se, but are important in Medicare Part D. And one is in the House bill, the gradual elimination of the Medicare Part D donut hole down to nothing by 2019. Whereas in the Senate bill, there is also a reduction, but it's less of a reduction in the size of the gap. But instead, there's also, in addition to that, discount envisioned for brand name prescription drugs that are going to be used in the donut hole portion of the plan. So those are, that was the whirlwind tour of the two plans, the two bills. And now we're going to get into some of those specific features we mentioned. So I'm going to talk about insurance market rules and Medicaid, and then turn over to Professor White. So the two things that, so as I said, there are going to be these big changes in insurance markets, and basically what are likely to be the consequences, I think, as a result of this, for those with existing medical problems. The new system is going to be a vastly different and improved way of purchasing insurance. Of course, there's a flip side to the coin, and that is that for the healthy, this is going to be very different too, and they're going to be paying a lot more. Because basically what we're doing is bringing the price to be equal. So it means taking the price of those with health conditions and those without health conditions and bringing them in order for the premiums to average out, be equal. So insurers may fear adverse selection as a result of this, especially when the fines for not purchasing coverage are not as high as what it costs to purchase coverage. So these are things that would be things to watch out for, concerns about insurers wanting to participate in the exchange. Within the market, there's risk adjustment to reduce fears of adverse selection for insurers. In terms of the Medicaid expansions, there's going to be a big expansion for adults, because for children, up to about 200% of the federal poverty level or more, there's S-chip now. So for children, this is not going to be really meaning much, but for adults, this will be a big change. There will be these changes to the S-chip program, and something to note is that usually a Medicaid expansion would involve a lot more state money, but in this case, the legislation is written so that is limited. So now I'm going to turn over to Will for the rest of the features.
So another feature that's stirred up a lot of debate is the public option. Now, I think it's actually the current bills have really scaled it back to the point where it's much less of an issue than it potentially could have been, but it's useful to just talk a little bit about why you'd want a public option, and B, what some of the concerns are surrounding it, what the kind of levers are that you could push and what implications they'd have. So basically, the standard arguments for public option are that there might be coverage gaps, that you might have situations in the exchange, for example, where there isn't adequate coverage available for people. And also the notion is, well, if we have a public plan, that'll keep competition maintained in the market. Now, kind of buried under this are some rather different visions, where in particular, some people who would like to have a single payer option, which isn't in any of these bills and we haven't really discussed. One notion is, well, if we can't have that, maybe we should have a public plan, where a very strong version of this is one where you would have the plan be able to pay providers Medicare rates, which are much lower than private insurance rates, and require the providers to accept the patients. And if you did that, you basically could create insurance plans that could underbid anybody in the commercial market. And if you allowed everybody to be eligible for those plans, it could really change the whole landscape of insurance. That is not what is being currently debated. That's certainly been floating around, but it's not where we are. So one issue is, what rates do you pay? The current proposals in both the House and the Senate bill basically are talking about plans which go out and negotiate rates with providers just like commercial insurance plans. So they're not going to necessarily have very much leverage. The other issue is eligibility, where current plans have relatively narrow eligibility criteria, so that it's not clear how many people would actually be able to come into these plans. One point is, if the plans are relatively attractive, especially for small employers who typically have low rates, you might see the employers simply dropping coverage and saying, hey, you can get a better deal and save me some money by going over to the public plan. The other issue is the extent to which you decentralize the decision to offer these, and the Senate plan basically calls for making this optional at the state level. Another thing that we may hear more about, because Senator Snowe from Maine is very interested in it, is the so-called trigger option, which is basically to say, well, we're not going to put public plans in the bill, but if you meet certain criteria, that is, there are problems with how insurance exchanges are working, then these plans can kick in. So I wouldn't be confident that that isn't going to come back as an issue, because she's a very key player in this debate. Turning to the tax treatment of health insurance, I think it's useful to step back and explain a little bit about the health insurance system. I made the argument that employer-based group insurance was dominant, partly because of problems of adverse selection. I didn't discuss the tax treatment, which is also a non-trivial factor. We might still have a group system, but it might look different if it weren't for the fact that during World War II, there were caps on wages, but the IRS ruled that firms could provide benefits as non-taxable contributions towards their workers. And the upshot was that since that time, employment-based insurance, not individual-based insurance, is tax exempt, where there are two big areas of tax exempt. One is payroll taxes like Social Security, which are regressive, and the other is income taxes, which are, as we know, progressive. So that's had some interesting issues. Economists, by the way, hate this subsidy because the argument is, or most economists, I should say, because really it involves a lot of money, not necessarily very well targeted, because when you think about where these subsidies are going to go, certainly on the income tax side, they're going to be highest for the highest wage earners, which is probably not the group you're most worried about. And they're also going to be highest for the most expensive plans, that is, holding people's income fixed. The people who have the most generous plans get the subsidies, and it's not clear that we want to encourage very high-priced plans. There was some discussion about actually dropping these subsidies, and that basically ground to a halt. But there has been, they've reemerged in the Senate bill through a proposed Cadillac plan tax. I'm not sure Cadillac is quite the analogy you want to use right now, but in any case, the basic idea is we don't think the government should be going out and heavily subsidizing very expensive health plans, because that's sort of encouraging overutilization of care. And I earlier mentioned underutilization, but another theme is overutilization, that when people don't have to pay for care, they may use more than they necessarily would if they had the ability to alternatively use the same money for other things, which suggests inefficiencies. And so these Cadillac plans under the proposal that Harry Reid is supporting in the Senate, there'd be a 40% tax, I believe at the insurance firm level, on plans on whatever was above $8,500 for individuals and $23,800 for families. These are very expensive plans. I mean, this is well above the average cost. I think an interesting question down the road is whether these things would be inflation adjusted or just sit there, in which case over time as base costs rose, they could start having much bigger impacts. But in any case, the idea is this would simultaneously bring in some revenue, and it would also discourage plans that are viewed as unduly generous. I think there are two issues floating around here, one of which there's been some attempt to address. That is that it might hit high-risk people, and there's now a whole string of people that are going to be exempted from this tax: coal miners, telephone linemen, policemen, etc. The other is that when you think about it, the policy costs are likely to be highest for small businesses who have problems pooling risk, and so you might accidentally swat people who have some of the biggest problems in getting adequate insurance coverage. You know, a small firm with sick workers is going to have very high premiums along the lines that Khosla was talking about. The other issue politically is that the unions have been very strongly identified with some of the most generous plans, and they aren't thrilled to see these things disappear, to be subject to substantial taxes. The final thing we were going to talk about, in other words, you want to chime in here, Khosla, but is one of the things you keep hearing about is the Congressional Budget Office CBO scores. Everybody sits around with bated breath as to what they're going to say when these proposals are laid down. As we noted, 70%, the current rate of uninsured is 17%. So 83% of the population has insurance. Under the House bill, the CBO is estimated that by 2019, we'd push that down to 6%. By the way, that's not so far off the share of the elderly population without health insurance. The House bill also contains higher subsidies, higher fines, higher taxes. Khosla was noting the tax on high-income families. So it would have a net cost of around $894 billion. And this would be financed by Medicare and Medicaid savings, the new taxes, and it would, at least theoretically, reduce the budget by about $104 billion. Now, I wouldn't interpret these as the gospel truth. I mean, in order to make these models, you have to make a lot of assumptions, but at least gives you some kind of ballpark idea. If we compare this with the Senate version is estimated to reduce the number of uninsured to 4%, to have net costs that are a little bit lower, $848 billion, basically be financed by the same means, except that they wouldn't have the tax on the wealthy, they would have the Cadillac plan tax, and it's estimated would reduce the deficit by about $130 billion. So the overall feature of these plans is that the claim is they will substantially reduce insurance. They won't be cheap, but that as designed, they will actually, by 2019, excuse me, reduce the deficit rather than increase it. So why don't we stop there?
This has been a production of Cornell University. On the web at cornell.edu.